So now we're specifically looking at gait by itself because this is just another movement screen. This is another a continuation of our discussion on movement, but it's a follow-up to our discussion that we talked about last week about posture and the limitations of posture. And that posture, again, is only a static position, and then that static position, we can make hypotheses about that position, but we need to actually test whether that person can get in and out of those positions. And we can do that by going through all the different types of movement screens we've discussed so far, but gait is another option. So again, testing static postural assessment should be followed up with some kind of gait analysis. So again, there's a normal variation in what we would consider as normal gait, and so majority of the people are going to be living kind of in this range of what we consider normal. Again, as they kind of extend towards either side of this slope, their motions are getting a little more dramatic, and as they start to live in these outer reaches along this bell curve, then we're going to consider that as being abnormal. And this, when people move in these patterns here, even the layperson can detect that somebody's moving in an non-normal way, right? So if we have somebody who's maybe got cerebral palsy or somebody who's had a stroke, right, they will move, and a layperson on the street can look and say that there's something that's not normal about how they're moving, right? They can detect that. So when people move through these kind of abnormal patterns, and it's drastic, it's easy to pick up, right? We're still not sure of maybe where that problem is coming from. So again, that takes some follow-up procedures to figure out maybe where the problem really resides. But it's these areas here where we're still kind of in that normal range, but we're getting towards these abnormal areas. And again, if patients don't have pain, then I'm maybe not real concerned with it. But if they reside in these areas and they do have pain, this is where looking at gait analysis, it becomes a little more tricky, and it becomes more complicated because you're looking at subtle little differences. And again, they're so minor that, again, they don't necessarily cause a lot of attention to them. It doesn't draw attention to these areas to say that's drastically wrong. So this is why we would use gait analysis in this situation. So this is gait analysis. Think of it like an MRI. That if you're treating a patient and you're having issues and you're not getting the result that you are expecting, then this is where you would rely on advanced diagnostic labs, right? So blood work, x-rays, gait analysis, motion analysis would fall into that category. It might give you some additional information that you weren't able to obtain otherwise, that helps kind of direct you your examination and your treatment. So this is when we would use gait analysis. And again, if we're treating people who live kind of in this normal range, again, if they don't have pain, I'm not going to be too concerned, because that could be a normal variance and normal variation of gait based on, again, arthrokinematics, and more of a structural thing potentially than maybe a functional problem. But when they do have pain, this is where we're going to start to rely on our movement screens and maybe potentially gait analysis. So in the notes here, I kind of provided one example of how when we see somebody in a certain position, posturally, that we can start to draw some kind of conclusions and hypotheses about maybe how they would move, right? And then we have to actually test that and see what happens. And then if we see people who have maybe, upper cross, lower cross position, that does change how they maneuver through life if they can't get out of those positions. So I have a couple of examples here that are hopefully easy to kind of pick out maybe the abnormalities in these gaits. So in this first one, we can see the individual going through this kind of sway back and forth, and there's a lot of frontal plane motion. And again, not 100% sure as to where this is coming from. This could be from a right ankle, could be from a right hip. But again, you can see how basically the entire body is going through this frontal plane motion. You can see through her, even her neck, how she goes through it and goes through lateral flexion considerably and more one direction than the other. So again, it's a unilateral motion. And again, if this patient's having pain, then this gets into the whole regional interdependence again, where we're going through and saying, well, where is this person's dysfunction residing? And if we address that, that could very well fix her cervical complaint, right? If she's running a lot, you can see why she might have a lot of neck pain. But the problem of going through lateral flexion as she's running may not be fixable by just going through and doing some kind of cervical manipulation and doing cervical rehab, because this may indeed live in her hip or ankle. In the next gait, we can see this individual going through, and again, we talk about pronation and supination quite a bit in the foot, and this person pretty much lives in a pronated position all the time. So again, how does this translate to the knees, the hips, the low back, right? And in the third version, the last example here, we can see how there's some medial heel whip. The right side, the foot kind of whips in, and you can see that might be a compensation pattern because of a lack of internal rotation in the hip, in the right hip. But in order for that person to compensate that and that rotation that's happening through the lower half, she has to compensate by reducing some of the rotation through her upper spine and thoracic spine. And you can see that in her arm swing, that she basically walks with a very rigid style. So again, as we're going through, posturally, she may have really, really good posture, right? But then we'd want to follow this up with gait, and we all of a sudden should detect that, hey, something doesn't look right here, and that should kind of, again, focus our attention to certain areas that we'd want to evaluate in our examination process. And then there are a couple examples of small little details between supination and pronation and different kind of compensation patterns. And these get a little more difficult to evaluate and see in real time because they're subtle and the transitions happen really, really quickly. So this is, again, an example of why you might want to use some kind of video analysis to play back in slow motion to tease some of these compensation patterns out. If your person's having some kind of pain or you suspect that there's an issue. So now let's review some of the specific pieces and components of gait. Now, if you recall, gait has two phases. There's a stance phase and there's a swing phase. So obviously the stance phase is where the foot's actually in contact with the ground and we're actually standing on the foot. The swing phase would be where we're actually swinging the leg through the air. And we can break down kind of what happens in each one of those, the stance phase and swing phase. However, majority of the time is actually going through and evaluating what happens when we're loading the structures through stance phase. So again, we can look at a gait cycle. So a gait cycle is basically from heel strike through full stance phase. So heel strike, mid stance, toe off, swinging the foot, and then making contact with the heel strike again. That entire process is considered one gait cycle. Now, when we're looking at a gait cycle, we can evaluate a lot of different things. One being the path of contact. So when they're heel striking, what part of their heel are they contacting? So ideally, we're looking for that kind of lateral edge of the foot, of the calcaneus, to be in contact, to make contact first with the ground. And then as they go through their stance phase, they're going to transition towards more of the medial side. So when they toe off, they actually go off the big toe. So we're looking at kind of their positioning in a sagittal plane and kind of how they proceed through their stance phase. But then we can also kind of go through and look at a gait cycle and evaluate, is there asymmetry from side to side or even unilaterally between a stride length, their step length, and their stride width. And again, stride length is just basically the distance that one foot unilaterally is covering with each step. The step length is basically the distance between the left and right foot, and the step width, or the stride width, is the distance between the left and right foot from a frontal plane kind of position, so how wide their feet are. And we know that if we were to draw a midline vector down the body and walked over top of this midline, like there was a line down the middle of the road, then our feet should remain on either side of that line, and then they should not cross over. So we are evaluating for these things as we go through and observe gait and do our gait analysis. Now, essentially what we're looking at when we're watching the lower body is we're looking at them to see if they are conserving momentum, and are they doing this efficiently. And as we go through our stance phase, swing phase, the knees and the ankle, the knee, and the hip are actually trying to absorb shock and conserve energy and momentum forward, so that every time we heel strike, we aren't actually halting our progress forward and then having to generate new force to propel ourselves to continue in that kind of forward momentum. So we don't want to actually be stopping and starting, stopping and starting. So the legs are actually there to absorb shock. And because they're doing that, because they're going through this kind of flexion, extension, alternating pattern, we do have this kind of up and down, kind of a bounding type motion, and a little bit of sway from side to side. So now what's interesting to note is that if we're looking at the lower body to perform the shock absorption to maintain that forward momentum, where is all this force production really coming from? That really the spine is responsible for creating all of this energy to move us forward. And again, in the context of rehabilitation, there is an understanding that basically all movement starts proximally in the core, and that allows movement distally. Okay, so the movement starts proximal, moves distal, and basically the spine and how we control that in our core is responsible for creating the energy and allowing the movement in our extremities. And gait's the same thing. We are basically, as we go through and rotate and do these reciprocal kind of motions through gait, we're actually rotating all the segments in the spine in opposite directions, and that actually is creating elastic energy so that when we move in a contralateral motion, that elastic energy is expressed, and it's basically allowing the spine to kind of spring in the opposite direction. And again, half the fibers are absorbing energy and half are giving off that energy. And this reciprocal motion is really important for the spine. And if anybody's having some kind of spine problem, probably the best thing for them to do is actually go through and walk. This helps maintain and promote good health to the core muscles. Again, glutes, lats, all the abdominals, all the small little muscles that are surrounding the spine, right? All these things that are basically helping promote some of this kind of contralateral motion and stabilization is going to benefit from going through kind of a normal walking kind of pattern. And if we're trying to evaluate this to see if this is actually happening efficiently, then we can't necessarily look at the spine because that becomes very difficult to evaluate. So we can see this, again, if it's starting proximal and going distally, generally we see these bigger kind of dysfunctions. They're more elaborate, they're more exaggerated distally. So we look at the arm swing, and we can pick up on maybe there's a lack of rotation happening to the spine because the arms they're not symmetric, they're not staying in the sagittal plane. We might start seeing some kind of frontal plane motion or just basically them being held right by their sides. So that is a clue that something is going wrong with just that kind of rotation and the ability for the spine to actually go through and create some of this energy.